Hello, my name is Derek Posh. I'm a respiratory therapist. I've been a respiratory therapist for about 4 years, and this is a presentation on COPD for Middle Georgia State University, Perspectives on Wellness class. I'm going to be talking about COPD education today. Um, so let's get started. So, what is COPD? COPD stands for chronic obstructive pulmonary disease. Um, it is a lung disease caused by smoking, primarily by smoking. About 90 plus percent of cases are caused to long-term smoking. It can be caused by secondhand smoke, as well as other dusts and chemicals in the workplace, such as farmers' dusts, uh, farmers have, or coal miner dust, or silica dust, or in some food industries, flour dust, but mainly it's caused by smoking. COPD is a worsening of a lung disease called emphysema. Emphysema and COPD are the same thing, they're a little bit interchangeable, um, just that COPD is worse than emphysema itself. There are a couple different stages of COPD. You can have stage one, two, three, or four, four being the worst. Um, COPD um, affects the lungs. Um, on screen here is a picture of healthy lungs. Uh, you have your different lobes of your lungs, and you have these really tiny small air sacs called alveoli here. That helps with gas exchange. You have CO2 in your body, you have oxygen in your body. You inhale oxygen and you exhale CO2. And when your lungs become damaged, it throws that out of balance. You actually tend to have more CO2 in your body and less oxygen. Um, with COPD, a lot of people have a very productive cough. They have sticky mucus in their lungs that they can't get out because their lungs are hyperinflated. And I'm going to show you a picture of some hyperinflated lungs. Uh, as you can see on here, on this chest x-ray, uh, these lungs are stretched all the way out to the thoracic cavity here. And there is actually a flattening of the diaphragm. I'm going to go to a picture of some regular lungs here. Normal lung x-ray. So a normal lung, you have good aeration. You can see some vasculature here, and these have these intercostal spaces, and you can see a nice rounded diaphragm here. As where in this hyperinflated lungs, that actually has a flattening of the diaphragm. So the lungs are hyperinflated and it's really hard to get air in because you can't stretch those lungs out anymore. And it's also hard to get air out because the elasticity of your lungs, the stretchiness, the rubber bandiness of your lungs is destroyed. And like I said, that's mainly caused through smoking. So, how is COPD? Uh, let's go actually real quick. Let's talk about some more symptoms and how you can get it. We talked about smoking. You can get it through uh, workplace exposures, such as welders who uh, will have a lot of fumes coming off of the materials that they're welding. You need to have proper ventilation in those type of professions. Farmers can have an exposure to grain dust, even if they're outside. Um, Over time, that can destroy lungs. And coal miners, um, they can have uh, miner's lung, and that's from breathing in all that coal dust. Uh, So how is COPD diagnosed? Uh, the main way the COPD is diagnosed is through an outpatient procedure called a pulmonary function test, also called spirometry. Um, it indicates how well patients can exhale, how well people can exhale, as well as how fast they can exhale in 1 second. It's called a forced expiratory volume. And most healthy people can exhale all of their air. If you really try, if you exhale all of your air, you can exhale about all of your air in 1 second. Excuse me, 80 to about 95% of your air. You can't actually exhale 100% of your air, um, because there is a little bit of residual air inside your lungs. But patients who have COPD um, can't exhale sometimes more than 40% in that first second. So it's because their lungs are so stretched and so open, and hyperinflated, uh, it's hard for them to exhale that. And um, patients who have COPD, their bodies are compensating all the time. So because they can't get enough oxygen into their body, they actually build up carbon dioxide, CO2, in their body, and their body tends to compensate for that difference. So they might have a much higher CO2 than a normal person, and because of that, um, they need more oxygen. And I have what I would normally put on the patient here. I've got just a little nasal cannula. I'm just going to show you how to put it on here real quick. So you just put it in the nose like this, and then you go over the ears. I'm sorry, 1 second, let me put this on. And you go around the ears just like that, and there they can be provided oxygen. Normally, you don't want to go above a very low amount, like 1 to 2 liters of oxygen, um, and that would supply their need to have a healthy balance of oxygen in their blood. Because they've been smoking for so long, uh, in the blood itself, in their bodies, the inside the hemoglobin that transports oxygen throughout the blood, throughout the body, and throughout the tissues, it's actually it doesn't have as much oxygen in it. It actually has carbon monoxide, which is a byproduct from the smoking because you're breathing in all that smoke. It's actually carbon monoxide, which actually has a greater affinity for binding to that hemoglobin. And so it's actually really hard to get oxygen to those tissues throughout the body. So a COPD patient doesn't require a lot of oxygen. Uh, and if you actually give them too much oxygen, because their bodies are so compensated with that change in CO2 and oxygen, um, you can actually cause them to become comatose and not be breathing because their body doesn't know what to do with all that oxygen. It's actually too much. So much of COPD and COPD care when I'm caring for a patient is kind of a balancing act, because their lungs are hyperinflated. They might have thick, sticky mucus inside their lungs. I need to try and get that out. And I'm also trying to compensate for how much oxygen they need. Of course, if they need more than a couple of liters of oxygen, I'm going to give it to them, but um, you don't want to give them too much because they won't be able to breathe. So, along with treatments, oxygen being one of them, a lot of patients and a lot of people are on nebulizers, and nebulizers are uh, now would be hooked up to this end would be hooked up to oxygen, and nebulizers are these little things here. You have a little bit of medication in here, and a lot of people do these at home. Uh, and when they get really bad and they can't control their symptoms, that's when they come in. Many COPD people have these and they take them about anywhere from 3 to 4 times a day. Sometimes patients take them every 4 hours. This would be hooked up to a gas source here, and you're going to be breathing in on this, and that allows them to take that medication into their lungs, open up their airways, help them expel some mucus, and clear out those lungs so they can have as much gas exchange as possible. Um, when their lungs get really bad, they can actually develop a pneumonia because they cannot get that sputum out of their lungs. Uh, so, like we said, nebulizers help open up the lungs. Oxygen helps them to have a safe level of oxygen. And how you can actually test that is through a little pulse ox here. It just reads, through an infrared light on here, and it's going to read through my finger, infrared light, read right into my tissues and to my hemoglobin. And as you can see, it says 99, 100%. It also reads your heart rate too. So this is what I do for patients. Many COPD patients, their their oxygen levels are high 80s, about 88%, and that's actually normal for them because their bodies have been compensating for so long that they live at that level. Um, a lot of patients um, don't require a whole lot of oxygen to go home with. Uh, you do have to. Sorry, I'm going to take this off real quick. Uh, a lot of patients are on such a low flow of oxygen, and when their symptoms get too much, that's when they come in. Like I said, I'm going to go to another picture here real quick. So right here, as you can see, here are some healthy alveoli. There's a very small airways in the lungs. This is where all of your gas exchange happens, in and out, in and out. And in COPD, they're so hyperinflated, they're actually ballooning outward more than what they're capable of. So it's really hard. And what happens is that they get this thick mucus, and it's really hard for them to cough out. Um, a lot of people who have COPD also need to be educated. So there's a thing called pulmonary rehab, and pulmonary rehab is a program and it's educational. It's involves a little bit of exercise, but it also helps them live with their symptoms and help them try to improve their symptoms through exercise. Uh, Many people do find lots of benefits through pulmonary rehab, and um, sometimes they get a chance to meet other people with their same medical conditions, so there's a little uh, support there as well. Um, and the main goal for pulmonary rehab is to decrease the need for hospitalization visits. Some people might need surgery for their lungs. You can take out some severe affected emphysemic parts of the lung to help them um, function better. Um, and once you have COPD, there is no cure for COPD. It's all about managing symptoms and managing flare-ups. Um, if their symptoms do get too bad or worsen and they can't get that mucus out, they can develop a pneumonia. And this is where there's a lot of infiltrates and a lot of um, white haziness here um, that affects the lungs themselves here. Here's another good picture of pneumonia. So these alveoli here are inflamed. They can't get this mucus out, and that causes an infection. So they can be treated with antibiotics. They can be treated with these nebulizers. Usually it's a combination of both, and hopefully we can help them enough to get them out of the hospital. Um, So I hope that was a good little education of COPD. Thank you very much for watching, and have a good day.